Welcome to the Funnel Effect. Today we are undertaking a critical deep dive, really getting into the weeds on a document that honestly outlines some pretty profound and concerning health disparities facing women globally. We're talking about the recent SCAIEAPCC expert consensus statement on cardiogenic shock in women. This is a really seminal piece of work. It was jointly developed with the European Association of Percutaneous Cardiovascular Interventions and the Association for Acute Cardiovascular Care, and importantly, it was ultimately endorsed by the Heart Failure Society of America. So, real heavy hitters involved here. Now, before we jump into unpacking the findings of this critical consensus, we absolutely have to acknowledge the extensive, very diverse group of experts who contributed. This wasn't a small undertaking. The authors include Suzanne J. Barron, Josephine C. Cho, Kayab Shah, Amanda R. Vest, J. Don Abbott, Mervit Alesnag, Christina Arigema, Emmanuel Barbado, Ravanya Bilamkonda, Anna E. Bortnick, Elaid Schifo, Robert Jan Van Goons, Cindy L. Grimes, Sigrun Halverson, Christian Hassiger, Navin K. Kapoor, Shahari S. Naidu, Vivian G. N., Jacqueline Saw, and Alexandra J. Lansky.
Yeah, it's quite a list, isn't it? And that list is long because the problem itself is immense and it really does span the globe. Our mission today really is to dive deep into this consensus statement because, look, cardiovascular disease is the leading cause of death for women worldwide. We're talking nearly 9 million lives every year. And we know that these sex-based disparities in treating cardiogenic shock, or CS, they're contributing significantly to tragically poor outcomes. So we need to understand the fundamental differences, in diagnosis and treatment, and maybe most critically, identify the massive knowledge gaps that are currently holding back better care.
Right. And the urgency of this mission, it feels like it's driven home by this one really quite shocking statistic you pointed out. While cardiovascular mortality rates, generally speaking, have trended downward over the last couple of decades.
Mm-hmm. Some progress there.
Some progress, yeah.
Mm-hmm.
But the consensus statement highlights that the in-hospital mortality rate for patients actually experiencing cardiogenic shock, it remains dismal. Yeah. Just stubbornly stuck between, 30% and 50%?
That's right. Pretty much unchanged.
And the truly staggering part is that despite all our technological advances, all the new devices and techniques, there's been virtually no meaningful improvement in that mortality rate in recent memory.
Sobering.
It really is. We seem to have a problem that technology alone just hasn't been able to solve.
And that lack of progress, it points directly to some profound systemic issues and diagnostic ones too. The core disparity we see kind of across the board is stark. Women are consistently less likely than men to receive the intensive guideline-recommended treatments, coronary interventions or advanced device therapies. And this is regardless of how severe their underlying disease actually is when they present.
Right. So it's not just about severity.
No. And not only are they often getting less aggressive care, but they also encounter these documented, really dangerous delays in receiving treatment in the first place.
That delay feels crucial. So let's try and understand why those treatments might be getting delayed. Maybe by exploring the fundamental differences in how CS actually starts, how it originates and presents in women. Cardiogenic shock is, it's typically categorized by its underlying cause, right? And the document makes it pretty clear those causes are not evenly split between the sexes.
Exactly. You've got acute myocardial infarction-related CS, so AMI-CS. That accounts for the biggest share, maybe 20% to 30% of CS cases in both sexes, usually stemming from, traditional atherosclerotic disease, plaque rupture.
The classic heart attack scenario.
Pretty much. But then you have non-ischemic heart failure CS, or HFCS. And that's actually more common overall, often making up 50% to 55% of all CS cases. And it's really inside this second bucket, the non-ischemic causes, where these sex-based differences truly widen.
You mentioned some key differences that seem to disproportionately affect women in that HFCS category. What specific etiologies should clinicians really be watching out for that might signal a different treatment pathway is needed?
Well, for one, women are statistically more likely to present with de novo HFCS. That means, new sudden onset heart failure causing shock. The incidence there is about 26% in women compared to 19% in men.
So a noticeable difference right there.
A significant difference. And then we have the conditions that uniquely affect women or are just heavily prevalent in women.
Like the non-atherosclerotic causes, the ones that maybe get missed more often.
Yes, exactly. Things like spontaneous coronary artery dissection CS or SCAD-CS. This is a really critical non-atherosclerotic contributor. It happens in up to 10% of all SCAD cases, and SCAD itself predominantly affects younger women. Then there's peripartum postpartum cardiomyopathy CS, PPCM-CS, which, well, by definition, is confined to that pregnancy and postpartum period.
And the consensus statement also emphasizes that even outside of those unique conditions, women are just far more likely to present with conditions that might look like an AMI, but actually need very different support.
Right. Precisely. They're statistically more likely to present with Takotsubo syndrome, TTS, the so-called broken heart syndrome. It's about 1% in women versus 0.2% in men.
Wow, quite a difference.
Yeah. And myocarditis, too, inflammation of the heart muscle. That shows up in about 13% of female CS patients versus only 3% in men. So the key takeaway here, I think, for the clinician listening is that if you see a woman in shock, you have to broaden your diagnostic search immediately. Don't just assume it's the standard atherosclerotic plaque rupture.
Because the management is totally different.
Fundamentally different. Managing SECDAD or myocarditis-related shock is just not the same playbook as AMI-CS.
Okay, that raises the question then about the underlying biology. Why? Why do women seem more susceptible to these non-succemic shocks? And why does their heart sometimes seem to fail differently? Did the document get into the hormonal context at all?
It does, yeah. The source material notes that estrogen, generally speaking, plays a protective role. It provides some pretty significant anti-inflammatory effects, helps shield against cardiac cell death, reduces oxidative damage. It seems to offer some protection against adverse cardiac remodeling over time. And this makes sense when we look at general cardiac health in women before menopause.
Okay, that sounds straightforwardly good. But I think I recall reading a sort of counterintuitive point about something called ischemic preconditioning.
Correct. There's this really fascinating paradox. These same hormonal differences, this protective estrogen environment, might paradoxically decrease ischemic preconditioning compared with men.
Okay, what exactly is ischemic preconditioning again?
It's basically a natural process where short, non-damaging periods of restricted blood flow actually protect the heart muscle against a larger future ischemic event, like a full-blown heart attack. It kind of primes the heart. So if women have less of this inherent defense mechanism, it might contribute to different outcomes during an AMI, even if they technically have less underlying plaque disease to begin with.
Huh. So the very hormone that protects in some ways could also leave them a bit more vulnerable when a catastrophic ischemic event does actually happen.
It seems to be a very complex biological tension, yes. And furthermore, the fluctuating levels of estrogen during major life transitions, think pregnancy, postpartum, and importantly, menopause. These fluctuations are known to contribute directly to conditions like PTCM and SCAD.
Right.
So hormones aren't just protective. Their flux, their change seems to be a potent driver of disease in this specific population.
This leads us to what I think might be the most critical clinical insight from the entire consensus statement, actually. This idea of the mischaracterization of presentation. If the causes are different, it sounds like the visible symptoms, the way patients look, are often misinterpreted.
This is, I believe, the absolute nexus of the problem that leads to those treatment delays we talked about. The data is quite clear on this. Women with AMI-CS often present with a higher left ventricular ejection fraction, or LVEF, that's the standard measure, how well the heart pumps.
Yeah, the percentage squeeze.
Exactly. And they often have similar or even lower rates of traditional end organ damage, like acute kidney injury or liver problems, compared to men presenting with the same diagnosis. So on paper, if you just look at those numbers, they might look more stable or maybe less severe than a man with the same condition.
But the reality is the opposite. They're suffering from just as severe shock, potentially even worse shock.
Precisely. The crux of the issue really gets revealed when you do invasive monitoring. Despite that outwardly perhaps reassuring LVEF, women actually exhibit significantly worse cardiac contractility overall. And this is reflected by things like a lower cardiac index and, importantly, a dramatically lower cardiac power output. Cardiac power output is arguably a much more sensitive measure of the heart's actual failure, its pumping ability, than LVEF alone.
Why is LVEF so misleading here? I mean, if the heart muscle is contracting visibly well on an echo, why is the patient crashing? What's going on?
Well, it's likely related to a few things. Differences in cardiac size, perhaps the way the shock state is being maintained hemodynamically. You see, a patient can have a relatively preserved LVEF, but still suffer from profound issues with volume status or severe problems with systemic vascular resistance, how clamped down their blood vessels are. If their body's own compensation mechanisms are kind of masking the poor output for longer, or if the heart is contracting inefficiently due to something like Takotsubo, where only parts are working well, then the visible LVEF might be deceptively high.
Right. So the consequence is lethal. Because the clinical picture seems less dire, maybe lower organ failure markers, perhaps less dramatic hypotension initially women can be, and often are, mischaracterized as clinically stable for far too long.
Mm.
They might be suffering from ongoing systemic hypoperfusion, where blood just isn't reaching vital organs adequately, but maybe without those really obvious warning signs like crashing blood pressure that men more typically display.
Oh.
And this subtle but absolutely profound clinical difference leads directly to those critical delays in starting the advanced treatments they actually need. #2, diagnosis, monitoring, and the knowledge gap.
And to combat that deadly mischaracterization, the consensus statement really stresses the absolute necessity of using objective measures. We need early diagnosis and accurate risk stratification. And the first, probably most accessible tool for this is the lactate level.
The lactate barrier, as we called it. We know lactate is an objective biomarker. It strongly correlates with mortality in pretty much all types of shock, and it's universally recommended for frequent measurement. It seems like such a basic thing, an easy blood draw that can tell you if that systemic hypoperfusion you just described is actually happening.
It should be basic, yes, and yet we see this massive disparity in its actual application. The Global Recover 3 study, which looks specifically at AMICS, revealed a really staggering data point. Only 1 in 4 women in that study had their lactate levels measured before receiving a percutaneous coronary intervention, or PCI, opening the blocked artery.
Only 1 in 4. Compared to men.
Compared to men, where 1 in 2 had pre-PCI lactate measurements. Half of men, a quarter of women.
Wow. That means that for 3/4 of the women in that major study, the clinical team was potentially operating without the single most objective piece of data available to really assess how severe that systemic hypoperfusion was.
Exactly. It's a huge diagnostic delay, and it just reinforces this idea that if a woman doesn't present with those classic, crashing symptoms, the clinical urgency is often underestimated, and basic diagnostic steps like checking a lactate get skipped or deferred.
Okay, so if we miss the early signs with the simple biomarker like lactate, the next level of certainty really requires invasive monitoring, doesn't it? This is where the pulmonary artery catheter, or the PACE, comes into play, the Swan Gans. It gives you that hemodynamic reality check when the clinical picture is, well, murky.
PACs provide absolutely indispensable real-time hemodynamic data. They tell us the specific pressures inside the heart and lungs. This allows us to accurately phenotype the shock. Is it primarily a failure of the left ventricle, the right ventricle, or is it biventricular failure? And this data is just essential for guiding the rapid escalation of care, deciding what support is needed next. But unsurprisingly, women with CS are consistently less likely to receive PAC monitoring.
Why is this monitoring so crucial, maybe especially for women, given what we've discussed?
Well, precisely because of that subtle presentation we talked about earlier. The PP bypasses the ambiguity of the clinical exam, even the ambiguity of the LVEF, by giving you the hard numbers, the cardiac index, the pulmonary wedge pressure, the CVP. Knowing the cardiac index is low, even if the LVEF looks preserved on the screen, that's the objective proof. That's what dictates placing a mechanical support device. And retrospective studies do confirm this. Early targeted PAC use, especially using it before starting temporary mechanical circulatory support, or TMCS, is associated with lower mortality across all the different shock stages. It just takes the guesswork out of the equation.
So the consensus is pretty strong here then. PAE monitoring is advised early for women who have persistent symptoms, or maybe whose end organ function seems to be worsening despite initial drug treatment.
Yes.
And the consensus makes its strongest recommendation that a PEG should be strongly considered in essentially all patients placed on any form of temporary mechanical circulatory support. It's about driving decisions with data, not just symptoms.
Absolutely. Data-driven escalation. Now, moving beyond diagnostics to the initial treatment phase, we hit what the statement calls the pharmacologic unknown. Inotropes and vasopressors drugs to support heart squeezing and blood pressure, they are the absolute first-line treatments for CS. They're fast, they're readily available everywhere.
Right, the go-to drugs.
Yeah.
But the problem is, the optimal pharmacologic agent for hemodynamic support in women remains largely unknown, doesn't it? It's due to this sparse, sex-based data again. This sounds like the first big clinical dilemma. You need to quickly restore pressure, but you're worried about the risk of drug toxicity.
It's a very, very difficult tightrope walk for the clinician at the bedside. We do know, based on retrospective evidence, that aggressive escalation of vasopressors and inotropes. Well, if it comes at the expense of delaying needed mechanical support, it should be actively avoided in women.
Why specifically in women?
Because the data suggests that women suffer higher mortality compared to men when this kind of delay occurs, when drugs are pushed really hard instead of moving to a device.
Okay, but hold on. Aren't vasopressors the fastest way to stabilize a crashing patient? Isn't delaying that for TMCS, which takes time to place, a major risk in itself? How do clinicians balance those two immediate dangers in a female patient who's hypotensive?
That is the absolute clinical challenge, isn't it? You must stabilize pressure, yes, but you have to do so recognizing that every minute spent aggressively escalating those vasopressors might actually be damaging the heart further, particularly in a female patient. The mechanism is highly plausible. Women may just have a greater susceptibility to the toxic effects of these drugs.
Yeah, so.
Well, vasopressors increase myocardial oxygen consumption, meaning the already struggling heart has to work even harder. They carry a higher risk of arrhythmias, abnormal heart rhythms, and potentially they can even reduce blood flow in the tiny vessels, the microcirculation, and end organs, possibly exacerbating that systemic hypoperfusion we keep talking about. So the consensus is essentially cautioning. Look, if you are reaching what you consider maximum safe doses of vasopressors and the patient isn't responding adequately, don't just keep pushing higher and higher. Pivot. Pivot immediately to considering mechanical support.
Okay, so given that potential toxicity from aggressive drug escalation, the consensus advises early consideration of temporary mechanical circulatory support, TMCS. But this leads to what the statement calls the TMCS paradox. It's advised early for women in CS to avoid that drug toxicity. But this is immediately complicated by the significant complication risks inherent in the TMCS devices themselves. It sounds like a catch-22.
It really can feel like one. Let's break down the history of mechanical support a bit in this context, because these three major trials kind of track the last decade or so of how we've approached this. First, we had the intra-aortic balloon pump, the IABP. Its use has declined really sharply since the big IABP-SHOC SUCU trial. That study showed no overall mortality benefit for AMICS, and crucially for this discussion, no specific benefit for the small subgroup of women who were studied either.
So the balloon pump is mostly out for routine use.
It's largely become a tool of, last resort or for very specific niche uses now.
Then came the microaxial flow pumps, things like the Impella device. And their use has increased dramatically, hasn't it? But as you noted, the data seems really mixed, especially for women, dramatically underpowered and sometimes even contradictory.
Correct. Let's look at these conflicting narratives because it's important. First, you have the international CVA registry. This was observational data, but it suggested that women might actually derive a greater survival benefit from very early Impella support, specifically pre-PCI, meaning putting the device in before the blocked artery was even opened.
Yeah, greater benefit.
That's what the registry suggested. In that specific data set, survival for women was reported as 68.8% with that early support versus only 24.4% if the support came later. That signal, though observational, suggests that really prompt action with the device could be life-saving in women.
Okay, that registry data gives us, immense hope for acting early. But then came the Danger Shock trial, the gold standard, the randomized controlled trial. What did that show?
Right. Danger Shock did show an overall mortality reduction with the Impella CP device compared to standard care alone. And initially, that was seen as a major breakthrough for Impella in AMICS. However, and this is a huge however, that trial only enrolled about 20% women. Just 1 in 5 patients were female. That's a major failure in representativeness right there.
20%. Wow.
And here's the real kicker. In the female subgroup specifically, when they looked just at those women, that overall mortality reduction completely disappeared. It vanished. The hazard ratio was 1.01, which basically means, statistically, women derive no discernible survival benefit whatsoever compared to just standard medical care.
That just highlights the absolute danger of extrapolating overall trial results when women are so dramatically underrepresented, doesn't it?
Yeah.
You just cannot assume the benefit applies to the subgroup that wasn't adequately studied in the first place.
Precisely. And that non-benefit for women came with a really serious trade-off in safety for the overall cohort, a trade-off that is profoundly important when we think about women specifically. The overall group in Danger Shock experienced a 2-fold increase in serious bleeding events and, alarmingly, a 5-fold increase in vascular complications, things like acute limb ischemia, losing blood flow to the leg.
A 5-fold increase in vascular complications. That's terrifying. That's not just some minor side effect. That means a patient who just survived a massive heart attack might now lose their leg or need emergency vascular surgery, which we know nearly doubles their in-hospital mortality risk anyway.
That is the stark reality, and because the Danger Shock trial did not report those complication rates by sex, we are effectively left in the dark. We simply don't know if that 5-fold increase was evenly spread or if it was even higher in the women enrolled.
And we have reason to suspect it might be higher in women.
We do. We know from other large consortium studies, like the CSWG group, that women are inherently more susceptible to vascular complications. This is likely due to smaller vessel size, maybe differences in vessel integrity, so the risk-benefit equation for an individual female patient might tilt far more dangerously toward harm than it does for the average male patient.
So where does that leave us? The resulting consensus tip for AMICS sounds like it has to be extremely cautious then.
It is. It says selective early Impella use, so before or early in the PCI procedure, is considered reasonable for women who are not in a coma. But the consensus strongly states that more randomized evidence with adequate pre-specified female enrollment is absolutely imperative to resolve this critical clinical uncertainty. We need better data.
And we see a similar pattern, maybe even worse, with the other main TMCS option, VA ECMO, venar arterial extracorporeal membrane oxygenation.
Yes, a consistent lack of benefit and a high harm profile there too. Data from recent randomized controlled trials like the ECLS SOC trial, and also a meta-analysis pooling data from 4 trials. They consistently failed to show any mortality benefit for putting patients on VA ECMO early in AMICS. Mortality remains stubbornly high, around 47–49% at 30 days in both the ECMO groups and the control groups.
No survival benefit and the harm profile, similar to Impella.
Similar and arguably even more pronounced in some ways. VA ECMO was associated with a 2.44 times higher relative risk for moderate or severe bleeding compared to controls, and a nearly 3-fold higher risk, 2.86 times, for peripheral vascular complications that required surgery.
Wow.
So given the complete lack of mortality benefit in these rigorous trials, combined with this massively elevated risk of severe bleeding and vascular injury, well, the consensus statement makes it unequivocally clear. It does not support the routine use of VA ECMO in women with AMICS.
So again, it comes down to very selective use.
Highly selective. Individualized decision-making based on the specific patient's hemodynamics and clinical picture is absolutely key. Routine upfront use is not supported by the evidence.
Okay, let's shift gears now to a really critical, highly specialized area. Cardiogenic shock in the peripartum setting. So during pregnancy or immediately following it, you mentioned it's rare, but when it happens?
When it happens, it is catastrophic. That's the right word. CS in this context. While rare occurring in only about 3.8 out of every 100,000 hospitalizations, it's associated with an alarmingly high maternal mortality rate. We're talking 18.8% for those women with CS versus a tiny fraction, 0.02%, for pregnant or postpartum patients without CS.
18.8%. That's staggering. And the main driver here is PPCM.
Yes, peripartum cardiomyopathy, PPCM, is the primary driver. It accounts for over half, 56%, of CS cases during pregnancy, and the vast majority, 82%, of cases in the postpartum period.
And the second major cause you mentioned was SCAID in pregnancy, spontaneous coronary artery dissection.
Right. The statement notes that SAD is actually the most common cause of an acute MI, a heart attack, during pregnancy. And pregnancy-related SCAD often seems to be more severe than SCAD occurring outside of pregnancy. It frequently presents as a STEMI, the more serious type of heart attack, and often comes with severe left ventricular dysfunction right from the start.
So how is the approach different for pregnancy-related SCAD-CS?
It's quite distinct. Because SCAD lesions, these tears in the artery wall, typically heal spontaneously over time, the primary strategy is often patience combined with robust support. Temporary mechanical circulatory support, TMCS, is often used here. But the goal isn't necessarily revascularization like in AMICS. It's more about achieving complete myocardial rest, just unloading the heart entirely to allow that coronary artery dissection the best chance to heal on its own.
Makes sense. But specific data guiding TMCS in this very specific group must be limited.
Extremely limited, unfortunately, but the principle of unloading for healing is sound.
The management logistics here sound incredibly complex. It must require a unique, very rapid, multidisciplinary coordination effort.
Absolutely. The consensus strongly emphasizes that a multidisciplinary pregnancy heart team isn't just a nice to have. It's paramount. It's essential. This team has to include cardiology, high-risk obstetrics, anesthesia, critical care, often cardiac surgery on standby, all coordinating in real time.
And clinically, there's a small but potentially life-saving procedural detail mentioned.
Yes, a tiny detail but crucial. During any cardiac procedure, or even just positioning the patient in bed, placing the patient with a slight left lateral tilt is required, especially in the second or third trimester.
Why the left tilt specifically?
It's to relieve aortocaval compression. If a pregnant patient, especially later in pregnancy, lies flat on their back, the weight of the gravid uterus compresses the major blood vessels running behind it, the aorta and the inferior vena cava. This compression significantly reduces venous return to the heart, lowers preload, and therefore drops cardiac output. In a patient already in shock, this compression will catastrophically worsen their condition. Tilting them slightly to the left takes that pressure off. It buys the heart crucial time by optimizing volume return.
Got it. Simple but vital. And the pharmacology, the drug choices, also have special considerations given the pregnancy or recent delivery.
They do. The preferred inotropic agent, if it's available, is levosimendan. It's chosen precisely because it supports heart function without significantly increasing myocardial oxygen demand, which is really crucial in a stressed maternal heart. If levosimendan isn't available, which is the case in some regions like the US for this indication, clinicians typically have to resort to the standard agents like dobutamine and norepinephrine, used cautiously. And for PPCMCS specifically, there is one targeted therapy: bromocriptine. It's a dopamine agonist that inhibits prolactin, a hormone implicated in actually causing or worsening PPCM.
And this drug, bromocriptine, it's associated with higher rates of left ventricular recovery in some pilot studies I read, though it's still considered experimental in places like the US and Canada.
That's correct. There have been promising pilot studies, and it's currently being investigated properly in a larger trial called the Rebirth trial. But the potential for recovery is what drives the entire strategy here. The overarching preferred approach for PPCMCS is fundamentally a bridge to recovery strategy. This is because many women with PPCM, though certainly not all, demonstrate at least partial, sometimes even full LV recovery over weeks or months.
That is a fundamental difference compared to, say, AMICS, where the shock is usually due to irreversible muscle damage from the heart attack.
Exactly. It offers a different kind of hope. However, the clock is still ticking very loudly. If significant recovery doesn't start to occur relatively quickly, say within the first 7 to 10 days than advanced long-term therapies, like considering a durable LVAD or even urgent transplant listing must be rapidly considered, because the rates of substantial recovery do decline quite precipitously if improvement isn't seen early on. #V, systemic barriers and advanced heart failure disparities.
Okay, let's bring the focus back now to the systemic and, well, the physical barriers that fundamentally seem to hamper care for women with CS across the board. We need to circle back to those highly dangerous complication rates we saw with TMCS, particularly vascular complications. This seems to remain one of the greatest threats to survival, especially for women.
It really does. The consensus statement emphasizes this danger repeatedly. That CSWG consortium study, which didn't include a decent cohort of women, about 30%, found that women had significantly higher rates of adjusted vascular complications requiring intervention, think surgery, or stenting. It was 10.4% in women versus 7.4% in men.
A noticeable difference.
And importantly, female sex itself was independently identified as a significant risk factor for acute limb ischemia. We talked about how devastating that can be.
We need to understand the mechanism driving this disparity a bit better. Why? Why are women inherently more susceptible to these vascular complications when large devices are inserted? Is it just about size?
Size is definitely a major factor. Women generally have smaller body surface area and critically smaller arterial diameters, particularly the femoral artery, which is the main access site compared to men. So placing a large bore access device, which is necessary for things like Impella or VA ECMO cannulas, into a smaller artery significantly increases the risk of dissection, bleeding, vessel closure, and acute limb ischemia. Beyond just size, there may also be inherent differences in vascular elasticity or vessel wall integrity that contribute to fragility, although the data on that is a bit more observational.
Now, the consensus warns against clinicians becoming overly fearful and avoiding potentially life-saving procedures just because of this higher complication risk in women. So the solution isn't avoidance, it's better practice.
Precisely. The solution lies in the aggressive, universal implementation of best practices whenever obtaining large bore arterial access. This means mandatory, universal use of imaging guidance for every single procedure.
Like ultrasound.
Yes, ultrasound guidance to see the vessel directly, fluoroscopy, real-time X-ray to guide the wire, and using micropuncture techniques, which start with a much smaller needle before upsizing. These steps standardize the procedure, minimize trauma, and directly mitigate the risk factor associated with female anatomy. The consensus also makes an urgent call for device innovation. We desperately need smaller, lower-profile TMCS systems to reduce this burden.
Okay, so that covers the acute phase complications. But beyond the immediate shock event, these systemic inequities seem to continue right into long-term advanced heart failure care, specifically concerning left ventricular assist devices, LVADs, and ultimately cardiac transplantation.
The underrepresentation in trials here is just, well, it's shocking, frankly. Women remain profoundly underrepresented in the major LVA trials, typically only making up about 20% of participants in landmark studies like Momentum 3, which tested the current generation of devices. And while the current continuous flow LVAs generally show similar overall survival rates between men and women now, which is an improvement from older devices, women still carry a higher specific risk profile for major device-related complications.
Could you break down that specific risk profile for the listener? What are women more likely to experience with an LVAD?
Sure. For the contemporary HeartMate III device, the large Momentum 3 trial data showed that women had an increased adjusted risk of stroke about 1.5 times higher. They had more major bleeding about 1.3 times higher, and more device-related infections about 1.1 times higher.
Why? What's thought to be driving those increased risks?
Again, sizing likely plays a crucial role. LVDs are mechanical pumps that take up considerable space inside the chest cavity. Women, often having smaller chest cavities and lower body surface area, may experience more challenges in optimal device positioning. This might contribute to things like inflow or outflow cannula obstruction, potentially increasing the risk of pump thrombosis, which can lead to stroke, or the device might just be more prominent under the skin, potentially increasing infection risk at the driveline site. Device fit matters.
And this disparity, this inequity, extends right up to the ultimate treatment for end-stage heart failure: cardiac transplantation.
It absolutely does. Women consistently account for only about 23% of all heart transplant recipients in the U.S. That number has barely budged for years. And when you look specifically at women who receive an LVAD as a bridge to hopefully getting a transplant, data from UNOS, the United Network for Organ Sharing, showed they had markedly lower rates of actually receiving a heart compared to men. Only 55.1% of women bridged with an LVAD got transplanted versus 67.5% of men.
That's a huge difference in actually getting the organ.
It is. And consequently, they had greater waitlist mortality. Women bridged with an LVAD had a 7.0% chance of dying while waiting, compared to 4.2% for men.
That is a dramatic, truly life-or-death disparity while waiting for a donor heart. What is the biggest driver thought to be behind this inequity on the waitlist?
Well, one key biological contributing factor is higher rates of allosensitization in women. This refers to the presence of preformed antibodies in their blood, often resulting from prior pregnancies or sometimes blood transfusions. These antibodies make them immunologically reactive against a wider pool of potential donor tissues. This means it's harder to find a suitable, immunologically compatible donor heart for them, leading to longer wait times and thus increasing the risk of dying while waiting.
But does allosensitization explain the entire gap?
Experts generally agree that while allosensitization is a significant factor, it does not fully explain the magnitude of the disparity we see. It underscores that there are likely also systemic failures in organ allocation policies, in transplant listing decisions, and perhaps even in referral patterns for transplant evaluation that disadvantage women. These factors remain poorly understood and need urgent attention.
Which brings us kind of full circle, doesn't it? Back to the overarching systemic failure that this consensus statement details so clearly. It links the diagnostic delays, the pharmacologic unknowns, the conflicting TMCS evidence. It all seems to stem from this core problem: the trial enrollment failure. The persistently low enrollment of women in clinical trials across the entire spectrum of care, from revascularization to TMCS to advanced heart failure therapies, seems to be the single major impediment to establishing truly evidence-based, sex-specific care.
It really is the root cause. Without robust data specifically on women, we are forced to rely on extrapolation from data predominantly gathered from men. And as we've seen throughout this discussion, that extrapolation is often inaccurate and, frankly, dangerous. It leads directly to the kinds of disparities we've been talking about. The consensus offers a powerful and I think necessary solution here to try and break this cycle. It explicitly calls for setting a pre-specified quota of women in ongoing and future clinical trials related to cardiogenic shock and its treatments.
A quota. That sounds quite directive.
It is, but perhaps necessarily so. This kind of structural change is likely essential to finally gather the high-quality evidence needed to inform best practices for treating half the population appropriately.
Okay, so quotas and trials are one major proposed solution. What other systemic improvements, maybe outside of trial design, are being championed right now to try and level the playing field?
Well, standardization of care is absolutely key to reducing sex disparities that might arise from individual clinician biases or inconsistent practices. So the consensus strongly advocates for systemic improvements, particularly the widespread implementation of multidisciplinary shock teams. We touched on this for pregnancy, but it applies across the board. These dedicated teams, typically including interventional cardiology, heart failure specialists, critical care physicians, often cardiac surgeons, they ensure faster, more appropriate, and more standardized treatment protocols are applied to every patient. And studies have shown this team-based approach demonstrably reduces sex disparities by taking some of the individual decision variability out of the equation.
Makes sense. Standardize the response.
Exactly. Furthermore, we're starting to see the development of potentially helpful gender-specific prediction tools. For instance, the document mentions the new SXSOC K-score. This uses machine learning, looking at variables like whether there's ST segment elevation on the EKG, creatinine levels, C-reactive protein, and LVEF, but it weights them differently for men and women to provide a gender-specific risk prediction. The hope is that tools like this can help mitigate inequities in that very early risk stratification step, ensuring women are neither overtreated nor, more commonly, undertreated initially based on a score designed primarily for men. Hashtag oucher.
Okay, so to try and synthesize the really monumental work presented in this consensus statement, it feels like it serves as an urgent, living guide for clinicians. It forces us, to confront the reality that women presenting with cardiogenic shock often present differently. Sometimes they appear more stable than they truly are, and they're disproportionately affected by these non-atherosclerotic causes like SCAD, PPCM, and Takotsubo syndrome, which require different thinking. The imperative to address the documented delays in objective diagnoses like getting that lactate checked early, the chronic underutilization of PAC monitoring for getting real hemodynamic data, and tackling the systemic inequities in access to advanced heart failure therapies. It all seems crystal clear. We simply cannot afford to continue treating 50% of our patient population based largely on data collected almost entirely from men.
Absolutely. And that leads us directly to the critical final thought, the provocative question, perhaps, that we really must leave you, the listener, with today. It's one that has to guide clinical practice as we move forward with this knowledge. Given that the overall mortality benefit we see from leading TMCS devices, like Impella in the Danger Shock trial, is frequently offset, or at least significantly counterbalanced, by a statistically significant increase in major complications, specifically bleeding and vascular injury. And knowing, as this consensus confirms, that women are biologically and anatomically predisposed to significantly higher vascular risks, does the current risk-benefit equation for the routine use of these TMCS devices actually tilt more dangerously toward harm for the average female patient than it does for the average male patient? If that underlying risk is higher and the benefit potentially less certain based on trial subgroup data, it makes that highly individualized, PAC-guided, objective decision-making process in women even more crucial than the consensus already strongly suggests. The evidence we use must truly match the specific patient sitting in front of us.
A truly vital area, it sounds like, requiring immediate systemic change in research. And, right now, much clearer, more cautious, and individualized clinical guidance at the bedside. Thank you for watching The Funnel Effect.